Okay, everybody, I'm recording our diabetic lecture because we're hoping it is now Tuesday. We're hoping that there's good results from a Super Bowl and that you can listen to this when you're paying more attention at 8 a.m. Monday morning after Super Bowl. So we've already done diabetes last year, so I'm hoping this will be kind of a review. The only thing I've done is add more medications. So, okay. Can't advance it, so skip it. Okay, advancing. So let's review from N305. Was this you in the corner here raising your hand, or was this you sleeping? We shall see. So the objectives are to discuss the physiological effects of insulin. So of course insulin's going to come back. It's a common drug. You're going to see it on HESI, you're going to see it on NCLEX, you'll probably see it on your test. Differentiate between two major types of diabetes. Remember, type 1, type 2. The three classic signs of diabetes and the main physiological risks for long-term and poorly controlled diabetes. Explain hemoglobin A1C, glycinated hemoglobin, which reflects what it reflects and why it's important. Differentiate among the different insulins, their therapy and mechanism of action. The main groups of oral anti-diabetic drugs, which there's a lot of classes of those, and I'll try and tell you which ones are most important. Main adverse effects. Summarize the causes, signs, and symptoms of diabetic ketoacidosis and hyperglycemia, hyperosmolar non-ketonic syndrome, HHNS. There are two things that I've added from last year. So again, the overview of diabetes. It's a disorder of carbohydrate metabolism. Remember, there's a deficiency in insulin, so there's not enough insulin, or the tissues are resistant to the actions of insulin. So there may be insulin in your body, but the tissues are saying, I don't want you to get out. So it's not doing what it's supposed to do. Again, it's sustained hyperglycemia. The cardinal signs, polyuria, polydipsia, polyphagia. So remember, what happens is the kidneys can only have a threshold for glucose. So if it gets about 180, it starts spilling into the toilet. So the kidneys can only absorb so much glucose into the body. And when the glucose levels get too high, the glucose starts to pour into the toilet. And with it, it starts to take fluid. So your polyuria, you're urinating, all this urination. Once that happens, you start to get thirsty because we've messed up our osmolarity, right? So you have polydipsia. Now, polyphagia, we talked about this last year. You're starving. Something is starving in your body. So I want you to tell me when we meet again, what is starving? Why are you starving with polyphagia? So type 1 diabetes, remember there's type 1 and type 2. Type 1A is, there's actually different subcategories. I just put this here. I'm not going to quiz you on all the subcategories, but this is the most common, type 1A, and this is an autoimmune disorder. So it's characterized by pancreatic beta cell destruction with severe insulin deficiency. So what happens is your beta cells that produce insulin are not functioning anymore, and there's antibodies that are actually attacking those beta cells. So again, antibodies to various components of the islet cells of the pancreas. So recall, this is the islets of Langerhans. Whoever discovered that, Langerhans got to name it. So inside here are your beta cells, also alpha cells, but these beta cells are actually what produces insulin. So it's those beta cells that allow insulin to get into the system. So type 2 diabetes, this has different effects going on. So what happens is it's insulin resistance in the peripheral tissues. So all that insulin, if there is any insulin on board, the muscles, the liver, the fat cells, Nobody wants to let it in. And recall, insulin unlocks the door to allow glucose to feed these organs. So it feeds your muscles, it feeds your liver, it feeds your fat cells. So if you don't have insulin on board, that glucose can't get to where it's supposed to go. The pancreatic beta cell dysfunction, so there's either an abnormal release of insulin in response to the glucose load, or there's not enough coming out at all. So basically the beta cells are, after a while, they start to get tired and they're not producing the amount of insulin that they should. There's also an increased hepatic glucose production. So remember I told you last year, I don't know if you remember, that your liver actually stores glucose. So in all of us, our liver stores glucose. So remember when I told you when I had clinical and my students would be on the floor from 6:30 in the morning to 2:30 in the afternoon and they didn't eat, but none of them passed out because remember, the liver releases glucose if you're not getting it in your meals. So what happens though in diabetics is they actually have an increased hepatic glucose production. So they have increased fasting blood sugars. The hepatic glyconeogenesis, which is the breakdown of glycogen into glucose, is actually malfunctioning. So they have too much insulin being released from the liver. So that's the traditional things going on, but wait, there's more. They also have an accelerated lipolysis in the fat cells. So what does that mean? And that's actually our next lecture. We're going to talk about cholesterol. So if you recall, the LDL is the low density lipoprotein. That's the bad cholesterol. And what happens in diabetics is their LDLs are small and dense. So that means they smack right up on the arterial wall and they cause patients to have issues with heart disease. So again, next lecture we'll talk more about statins, but just to give you a little preview, get you a little excited for next week. And they also have what's called an incretin deficiency in the small intestine. So what the fudge are incretins? And that's coming up in the lecture too. So all this excitement to come. Anything else? Yeah, diabetes is pro-inflammatory, it's pro-thrombolytic, it accelerates the aging phase. So we need to be proactive in diagnosis and treatment. And things are getting better. I can remember working in Florida when I did traveling nurse in the early 90s. And we had patients on the floor that were so mismanaged. They had continuous hyperglycemia and it really wasn't treated well. Now we're trying to see that, you know, diabetes is not a good disease. It's, you know, you can get blood clots, you can get cholesterol issues I just talked about. So it's really something that you want to be proactive and treat. Also, insulin resistance is also present in type 1 diabetics. So remember, type 1 diabetics, they're not producing any insulin, but if there is any insulin or we're giving them synthetic insulin, the tissues are saying, I don't want this. So keep that in mind when we talk about metformin, which I think we talked about last year, but I'm sure you forgot all that because your test is over now. Okay, so normal insulin metabolism is produced by the beta cells in the islets of Langerhans. So I talked about that already. It's released continuously into the bloodstream with small increments with larger amounts released after food. So when you start to eat, food gets broken down, goes through the stomach, hits the small intestine, and it's where that glucose is that the pancreas says, oh, let me release some insulin, the hormone insulin, to stabilize the glucose levels. And normal range is about 70 to 120. So again, there's a picture of the small intestine and the pancreas head. Okay, so again, insulin promotes glucose transport to the skeletal muscles and adipose tissue. So when insulin's out, it takes all that glucose and it actually is the key that unlocks the door to the cells. It feeds the muscle with glucose, it feeds the adipose tissue, and it feeds all the cells with glucose. Because if you don't have insulin on board, the glucose is just floating around your bloodstream, not doing what it needs to be doing. And it also stores glucose as glycogen in the liver. So it also takes some of that glucose and says, let me put this in the liver so that if we need it later, it will come out. And it also inhibits glyconeogenesis. So recall, glyconeogenesis is when the liver responds by releasing glucose because it says, oh, I think you need some glucose right now. But think about it. When insulin's out and about, it's saying, hey, we don't need you right now. I'm trying to get rid of the glucose that's out in the bloodstream. We want to inhibit any glyconeogenesis from the liver because we don't really need it right now. So it stops it when insulin's out and about. I'm not going to play this right now. You should look at this. It's actually from last year. The role of what insulin does just kind of sums up what I just said. And also there's a diabetic animation right here about what you eat. And again, I think these were actually from last year, but they're good, so I kept them. Okay, so type 1 diabetes. Type 1 diabetes, chronic. I think I already had this slide on here, but anyway, you're going to get it again. Autoimmune deficiency characterized by beta cell destruction with severe insulin deficiency resulting in hyperglycemia. I may have not had it worded like this. So again, type 1, they don't have any insulin on board, and they have severe hyperglycemia because all that blood sugar is running around in their bloodstream. They're also positive for antibodies to various components of the islet cells of the pancreas. So recall, in the islet cells are where the beta cells live. Okay, type 2 diabetes is the most prevalent form of diabetes. So this accounts for 90 to 95% of all cases of diabetes. It affects 22 million Americans. Again, it's impaired insulin secretion and insulin resistance. So a lot of times it's strong family history. We kind of talked about risk factors before. It can be age, obviously. As you age, the beta cells probably say, you know what, I'm getting tired of working all the time. You're 85 years old, I can't do this anymore. Or if people have poor obesity, poor diets, because they're eating all those carbohydrates, that again, the insulin's starting to work, the beta cells are working overtime. So after a while, the beta cells are starting to malfunction. So there's not enough insulin, and if there is any insulin, the tissues can be resistant to it. So complications of diabetes, short-term hyperglycemia, right? You're going to have high glucose levels in your blood. And we're going to talk about ketoacidosis and HHNK. So there are two things that have been added. And then hypoglycemia, because if we treat your hyperglycemia, it can result in hypoglycemia. Long-term complications, we have heart disease, we have hypertension, stroke, and altered lipid metabolism. So think about all those arteries. If they're filled up with all those lipids, they can put you at risk for heart disease, put you at risk for stroke, and high blood pressure. That's sustained hypoglycemia. So microvascular damage, retinopathy. Remember the sustained blood sugar, that high blood sugars start to do damage in those small vessels. So it's the vessels in your eye. Nephropathy, so your kidneys, the small vessels in your kidneys, that's when we want to put them on an ACE or an ARB. I'll review that with you again. And also neuropathy. So that sustained hyperglycemia starts to affect their nerve endings, especially in their fingers and their toes. So a lot of times they're at risk for amputation. Also, they lose sensation. So they can get infected easy. The higher your blood sugar is, the less functioning your neutrophils are. So when your blood sugar is sustainedly high, those neutrophils don't work as well. Also, remember, they have decreased sensation. So I don't know if you remember last year I talked to you about the lady that came in because, I forget the reason that she came in, but we found when we took off her shoes, she had a sewing needle stuck in her foot that she never felt and had this massive infection in her foot. Erectile dysfunction, because of all your arteries, if you're not getting blood flow down to your feet, you're obviously not getting blood flow below the belt. So a lot of times, older gentlemen that aren't even diagnosed with diabetes may come in and say they're having problems with erections. So this is one of the areas. So let's review the kidneys. Remember now, you have the afferent arteriole, which is right here, which brings blood flow into the kidney. And this stays dilated because of a substance called prostaglandins. So prostaglandins actually keep this permeable to allow blood flow to enter the glomerulus. So the glomerulus is this little membrane here, and it goes around this roundabout. And what gets past the glomeruli are just small molecules. You don't want to see anything big get through there. And the glomeruli comes then out through the afferent arteriole, E for exit. And that remains in a vasoconstricted state, which makes sense because the blood flow coming in, you don't want it all to pour out into the toilet. You want to reabsorb some back into the system, and you want to put some into the toilet. So that's the healthy kidney. That's the way it works, which again makes sense because you want this constricted as the blood comes in. So the diabetic kidney. So once again, we have blood flow coming into the kidney. It's got to go through the glomeruli, and then it's going to come out the efferent arteriole, the exit door. But what happens with diabetics is, remember I said prostaglandins are what keep this front door open, this increased prostaglandins. When you have diabetes, you have more prostaglandins, which actually causes more vasodilation in the kidneys. So now, instead of one lane of traffic coming into this kidney, now you got 3 lanes of traffic all coming into this kidney. So think about it. All that traffic's coming in. It's got to go through this glomerular membrane, and then it's got to come out this really constricted back door. So if you have all that pressure coming into that kidney, what's going to start to happen is this glomerular membrane is just going to start breaking down because it can't handle all that pressure coming in. And once again, you don't know that this is happening. Like I said to you when we talked about this last year, you don't wake up and go, oh, I've just busted a glomerular membrane on my right side. Oh, there goes another one on my left side. You don't know that this is happening. So that glomeruli is just being destroyed. And eventually these people can end up on dialysis. And if you took a survey in most of your dialysis centers, 9 out of 10 people sitting in those chairs have diabetes. So once again, how do we know that something's going on with their kidneys? Remember I said no big molecules should be spilling into that toilet. So if you're getting a big molecule like protein into that toilet, then you know you've already got some major damage going on this glomerular membrane. So what we're going to do when we bring you in for testing, the first thing we're going to do is test for what's called a microalbuminuria. So they're going to have you pee in a little cup, and if we see small molecules of protein, small microalbuminuria, we know that there's already some damage being done. So if we see that, we know we need to get you on a drug. And what drug would we want to put you on to open up that back door of that kidney? That's another question I'm going to have to save when I see you again. So polyphagia, and my next question is going to be what drug to open up that back door. Okay. Okay, so diagnosing diabetes, you have tests based on glucose. So we can do a fasting blood sugar test, a casual plasma glucose test. I had this on the slide from last year. Usually it's over 200, or an oral glucose tolerance test. The primary goal is to prevent long-term complications. So you want to have tight control of your glucose levels, and also control blood pressure and control lipids, because half the time diabetics die from heart disease and poorly controlled cholesterol issues. Okay, so again, keeping tight control of those glucose levels, because that's when long-term complications occur. So type 1 requires a comprehensive plan. You want to have diet, self-monitoring of their glucose, exercise, insulin replacement is needed. Type 1 diabetes, again, I'm not going to get into all the dietary measures because it's a course within itself, but what they do now is glycemic index. So, and this is a farm course, not a med-surg class. So calories that should be ingested from carbohydrates, fat, or metabolism, they look at the percentages of them. And remember, all carbohydrates turn to sugar, so they want to make sure they restrict them. Macronutrient distribution for any given individual is based on their current eating habits, preferences, and goals. So again, people with type 1, they usually know what their exchange system is, and we talked about this last year. They also have continuous glucose monitoring on their pumps. So again, the glycemic index, you can substitute low glycemic food loads for higher glycemic food loads to improve that glycemic control. So basically, they don't want their blood sugar spiking. They want to use foods that are not going to cause them that high spike in the blood sugar. So type 1, all type 1s need insulin replacement. You want to manage their hypertension. ACE inhibitors, for example, or an ARB can reduce the risk of diabetic nephropathy. Dyslipidemia, again, statins. Next week, we're going to talk about statins. So atorvastatin, for example, to control their cholesterol issues. Type 2, similar to type 1, but usually comprehensive weight loss and exercise. I don't know if you remember me telling you this before, but your beta cells actually respond to exercise. So if you're a type 2 and you're, obviously having beta cell dysfunction, when you exercise, it actually goes back and tells those beta cells to function better. So you always want to encourage exercise, and weight loss will do the same thing. And the great thing is the exercise lasts you can take 2 days off. The beta cells will actually function 48 hours after exercise. So if, just encourage them to exercise and they want to take the weekend off or Monday, Tuesday, whatever. So patients should be screened and treated for hypertension, nephropathy, retinopathy, neuropathies, dyslipidemia. So we need to check their blood pressure, we need to check their kidneys, we need to check their eyes, we need to check their neurosensation. Remember, I did we talked about in MedSurge, the monofilament testing, glycemic control, and of course, drug therapy. Self-monitoring of glucose, commonly between 70 and 130, 100 and 140 at bedtime. It varies if we're talking about different populations. So again, hemoglobin A1C, also called glycinated hemoglobin, provides an index of the average glucose levels over the past 2 to 3 months. So again, you had this last year, because recall, your red blood cells are produced every 120 days, which is 3 months. So what happens is, when you have that hemoglobin molecule, a certain amount of glucose leaches onto that hemoglobin molecule. That's normal. We all have a little bit that leaches on. I told you this last year. I have little A1C kits that I use for home care, and I checked my kids, myself last year. They were about 4.5. That's normal. Once it gets above 7 or 6.5, that's when we're looking at a diabetic. So the goal is to be below 7 for most patients. Remember, I last year had the American Endocrine Society and the Diabetic Society kind of said something different. So figure yourself around 7, that you want a goal for the diabetic patient. So that's how you monitor, is the medication you're giving them working okay. 8 may be appropriate for patients with a history of severe hypoglycemia or limited life expectancy. So remember, the elderly, we don't want their A1Cs to be too low, because they could have symptoms of hypoglycemia, get dizzy, fall down the steps, break a hip, and then the morbidity rate is increased. So again, A1C is what we use for monitoring patients that have diabetes, and to make sure our drug therapy is appropriate. Okay, so insulin, it's not going away. You'll need to know it again for this test. The discovery of insulin was discovered in 1921 by Frederick Banting and his assistant, Charles Best. They experiment on diabetic dogs. And finally, dog number 92, a colleague hopped off the table after the injection, wagged her tail, and it was a breakthrough. So again, we talked about this last year. Imagine how awesome this was. Everyone died within 3 months of knowing that they had diabetes. So when insulin was discovered, it was just remarkable. And again, these pictures are from last year. This was Elizabeth Hughes, who was the first American to get diabetes. Here she is coming to Toronto to get diabetes. They lived in, I think, North Jersey. So here she is when she came in, and then there she is after receiving insulin. So again, why does she look so cachectic in this picture, and why after insulin does she look much healthier? Another question for you. So again, Elizabeth Hughes, by the time she died in 1981 at the age of 74, she received 42,000 insulin shots that she corrected, or that she counted. So exogenous insulin. So all insulins have the same mechanism of action. So basically, insulin allows the glucose to go into the cells. It's the key that unlocks the cells. So it feeds your muscles, it feeds your fat, it feeds your cells. Insulin, human insulin analogs are modified forms of insulin that have the same pharmacological action as human insulin with different time courses. So you recall last year we talked about how the insulin used to come from pigs and cows' pancreases. Now we've extracted it as a human form. Again, insulin, all the same mechanism of action, but the time courses are different. So appearance, it can be clear or it can be cloudy, cannot be used interchangeably. So this is a high alert med because there's a lot of medical errors that happen if you picked up the wrong bottle of insulin or gave the wrong insulin pen. Number one medication that brings the elderly into the ER. So you think of all those new pens that they have. If their eyesight's bad, they can't see how much they're injecting. So again, number one medication that brings the elderly in the ER. I'm sorry, number two. What is the number one medication that brings the elderly in the ER? Another lecture from last year. See if you remember that. Okay, so high alert agents. Again, I already said that high alert. It's a recombinant of DNA technology. Human insulin is identical to insulin produced by the human pancreas. Then there's analogs, which are modified forms of human insulin, have the same pharmacological action, but a little bit different in time course. Again, when we talk about onsets and peaks, some of them are a little bit different if it's a different analog of the insulin. So don't get caught up on times. Remember, get a chart and remember the general times. I'm not going to split hairs when I ask you these questions. So again, you had these drugs last year, but they're coming back again. Short or rapid acting is Lispro, Aspar. I think I took this one out last year because I didn't see it as much, but I just included it in this slide. Short acting, so it's not as rapid as the Lispro and Aspar, but slower acting. Regular insulin. Only one in that category you need to know. The brand names are Humulin and Novolin, but regular is the name. NPH. Insulin, we had this last year, intermediate acting, and then long acting insulin is Gargine. I think I have these on all separate slides. So again, Aspar, Lispro, onset is 15 to 30 minutes after an injection. It lasts about 3 to 6 hours. Sub-Q is the usual route, or it can be given through a pump. So if people are type 1, they may have a short acting that just starts to give them insulin as they need it. It acts faster than regular. So this is one that you want to give when you're doing your blood sugars on clinicals, or if, I don't know if you do them for people at home, but this is one that you give with meals. So when and again, when most people are in the hospital, they're going to get their blood sugar taken because the stress and the illness bringing them to the hospital. Even if they don't take insulin at home, they're usually monitoring their blood sugars, AC and HS. So you're going to be doing one before breakfast, before lunch, before dinner. And if they're on a sliding scale, this is the insulin you're going to be giving. So you're not going to sit there and take your patient's blood sugar on clinical and it's 347. You're going to say, oh, let me give you an insulin onset that's going to act in about 6 hours. No, you're going to give them Lispro or Aspar. So again, you want to inject about 5 to 10 minutes before a meal, ideally. And sometimes it ends up you run late and you're injecting it with the meal, which I know happens. Ideally, that's what you want to do, because then if the meal's coming within 5 minutes, it's going to start to work. Again, this is another synthetic analog, rapid onset 10 to 15, shorter duration, should be administered close to the time of eating. Regular insulin, now we move into short, but it's a little bit longer than your Lispro and Aspar. This begins in about 30 to 60 minutes, peaks in about 1 to 5 hours, lasts for 10 hours. It's a clear solution. I used regular when we were doing clinical because for some reason they took the rapid actings off the floor. So we would give this with meals, but it takes a little bit longer to work. So you just have to watch your timing if their trays, not there. Okay, so intermediate is NPH insulin. This can be injected 2 or 3 times to prevent, to help with glycemic control. This is the insulin that's cloudy. So remember, this is the one that's cloudy. NPH is the only suitable one for mixing with short-acting insulins. NPH really isn't used that much anymore. It's cheap, one thing, but there's other insulins out there that they use, so it's administered sub-Q only. And again, this is the only insulin that's cloudy. Let me go back here one second. I don't have a slide on this, but they always seem to ask this about mixing insulins. And again, you may see it on HESI, but again, NPH is a cloudy suspension that must be agitated before administration. It's the only one that's suitable for mixing with short-acting insulin. So remember, when you're mixing them up, put them in alphabetical order, clear, then cloudy. So you want to do the short-acting first and then the cloudy suspension. Gargine, or Lantus is the brand name. That's modified human insulin. This has a prolonged duration of action up to 24 hours. So this one kind of mimics the pancreas. It just keeps releasing itself with over 24 hours. It doesn't really have an onset or a peak. Usually it's once a day to treat adults and children with type 1, and adults with type 2 can use it as well. And sometimes I've seen it given twice a day. So clear solution. Again, here's the chart I put in. Just kind of commit these times to memory and know that, you know, if they ask you when would it peak, you just kind of have to commit that too. Okay, so again, insulin appearance, except for NPH, all insulins made in the United States are clear, colorless solutions. NPH is cloudy. Patients should inspect their insulin before using it and discard it if it looks abnormal. So again, administration sub-Q, usually syringe or needle, or pens or injectors. Sub-Q infusion, we talked about the portable pumps last year, and IV infusion if it's an emergency in the hospital. So again, sub-Q sites, you all know these. Again, so insulin's primarily for diabetes, required by all patients with type 1 and many patients with type 2. Most insulin is sold to type 2s because there are more type 2 diabetics than there are type 1. We want to give IV insulin if someone comes in with diabetic ketoacidosis, which I'll talk about. Used for gestational diabetes for pregnancy. Used for hyperkalemia. So think about that, because why would it be used for hyperkalemia? So I'll give you a clue. Where does most potassium live in your body? So we'll talk about that. I don't think I tested you on that, but it's always good to know. Okay, so complications of insulin therapy. Obviously, if you're giving insulin to lower the blood sugar, you can lower it too much. So your patients can have a blood glucose level less than 70. It can interact with other drugs, so you always want to be sure of that. Blood glucose levels below 70, you want to do rapid treatment. If the patient's conscious, make sure you have something oral on hand, orange juice, a soda, glucose tablets, sugar cubes. If swallowing or no gag is reflex, nothing is given by mouth. We saw the clip on Seinfeld last year, remember, where he was unconscious and they were putting cookies in his mouth. That is what you don't do. So you want to give IV glucose or glucagon. And you saw that when we had Christina come in, she has a glucagon pen ready if she has anything. So again, common signs of hypoglycemia: shakiness, palpitation, nervousness, irritability, diaphoresis, anxiety, hunger, pallor. Now, another thing from last year, recall, what medication would you give, hint, 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 that might cause your you to mask your hypoglycemic reactions? So again, star next to it, that might be one. Okay. Drugs, 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 and more drugs. There's actually 10 classes of oral drugs and insulin. Wow, wow, wow. How are we going to memorize them all? Well, hit the key ones here. So I didn't give you all 10 drugs, but again, bioguanine, metformin, the only one in its class. We talked about it last year. It's the most common drug for diabetes. It's going to be seen on boards. It's going to be seen on the tests. It's going to be seen on HESI, I'm sure. Sulfonylureas, not as common, but they always still come up. Diaglidones, also known as the glitazones, I'll talk about them. Metagliptines, also known as the glindins, and then DDPP4 inhibitors, the gliptins. So we'll go through all these separately, but again, oral drug for diabetes, number one drug of choice for type 2 diabetes is metformin. Recall what metformin does. It doesn't have any direct action on insulin release from the pancreas, so it doesn't work in the pancreas at all. It decreases the hepatic glucose production. So remember I said in the very beginning that type 2 diabetics have issues. They're producing too much glucose in the liver. So it decreases the hepatic glucose production. So all the stored glucose in the liver, we decrease that production. But it also decreases the absorption in the GI tract. So remember when the when you eat and it starts to break up into glucose molecules in the small intestine, what metformin does is it actually takes it from the GI tract and puts it in the toilet. So again, diarrhea, a common symptom. So decreases glucose absorption via the GI tract and increases the receptor sensitivity of insulin to various tissues. So it also makes the receptor say, hey, let me take this insulin that's on board. So bioguanines are, I thought of another question. So when I come back, remember you're going to have to answer all these questions. Okay, so drug of choice for initial therapy, most common side effect is GI disturbances. Remember I said last year you have a lot of gas and diarrhea. So a lot of flatus because it's taking that glucose through the GI tract. Usually goes away, and like I said, sometimes tell them take it at night. Because if you're blowing gas in bed, who cares, right? Lactic acidosis. This is another one that you definitely want to keep in mind. Again, it's a question that always comes up. Hold for dye studies. Remember when you get if you ever have a dye study or arteriogram or when I had sentinel node, when they were trying to find if the cancer was in the sentinel node, they inject dye in to find that node. Arteriograms, anything that's looking at, that needs a contrast dye. The dye, when you see your patients on clinical, if they're going to the bathroom after this dye study, their urine's going to be blue because the dye comes right out into the urine. Now what happens, you don't hold them metformin and you give them dye, they'll both compete to get out of the toilet at the same time. And the dye will always win. So the metformin can build up in your system and cause lactic acidosis. Pretty rare, but it seems to be always a question that you'll see, what drug would you hold for dye studies? They also give it for polycystic ovarian syndrome because a lot of times there's issues with insulin resistance with those patients. Okay, so metformin, it's cardiovascular benefits. It lowers BP, increases your HDLs, which is your good cholesterol, and lowers your LDLs. Threw this information on here just because, like I said, it is really a drug that's a great drug. So you're going to see these things. Actually, weight loss is part of it. I said with the GI issues. It also reduces, this just came out in December of 2010. It reduces the risk of breast and prostate cancer by 54%. So that is huge. Again, not something you have to know for your test, but just something that's kind of interesting if you're starting when you study cancer in your senior year, you may see this. It actually blocks a pathway called the mTOR pathway that causes the cancer to metastasize. So again, oncologists are looking at this. Slows the aging process. It boosts neurogenesis, helps you think better. It's good for polycystic ovarian syndrome. I put this in here that they're using it for NASH, that non-alcoholic fatty liver. You may get a B12 deficiency with metformin, so keep that in mind. Again, contrast dye administration stopping metformin. That's really important to know. Decreases your A1C by 1.5 to 2%, which is great for diabetes. So this is when you're using the A1C. Your patient comes in, they've been on metformin for 3 months, whatever. They're getting their A1C monitored to see how well the drugs are working. Okay, next classification of drugs. I'm not sure if you're seeing these on clinical. You probably are. But they're old drugs, old. They're probably the first ones that were out. They're cheap, but they're not as good as metformin. But again, these used to be the first line drug, oral sulfonylureas. The names are glipizide, glyburide, and glimepiride. So you'll probably see these. I would think you would have seen these on clinical, but what do? They increase the secretion of insulin from the pancreas and increase the receptor sensitivity. So they actually stimulate the beta cells to produce more pancreas. Trying to say, wake up those beta cells. After about 5 years, these drugs really aren't effective. So they're really not first line anymore. But like I say, you'll see them, and you'll probably see them on Hesse's test. Problems, adverse effects. They actually make you gain weight. Hypoglycemia, because if we stimulate the beta cells too much, you can have hypoglycemia. So that's not a good option for your elderly that could be prone. Cardiovascular risks, and avoid alcohol with these drugs because of their the way that they work, stimulate, with their hypoglycemia risk. Glyburide has a long half-life, so you always want to make sure you don't want to use something with a long half-life in the elderly. So again, sulfonylureas were the first oral diabetic agents available, promote insulin release. Only type 2 would use sulfonylureas, not type 1. Major side effect, weight gain, hypoglycemia. So most type 2s are coming in with weight issues. So we're going to put them on a med that's going to make them gain weight. Not smart, right? First generation we don't really use anymore. The ones I showed you are second generation. They're having some cardiotoxic events, so and it's a sulfonylurea, so if they have a sulfa allergy, this would not be one that you want to use. Okay, I'm thinking that you probably see these on clinical, the metaglindins, which are the last name glindin. So repaglindin is also called Prandin. It's generally well tolerated. Again, hypoglycemic reaction. The other one, nataglindin, which is Starlic. It's near identical to that. So the two, again, you probably might be more familiar with these brand names, but the last name of glindin, their mechanism of action, similar to sulfonylurea, stimulates the pancreas, the pancreatic insulin release, and stops the rise of glucose. So these work really well. You take them before a meal, and they work well for people that have sporadic meal times, like people that travel and stuff. So it's usually that the insulin gets, the stimulation of the insulin gets released postprandial after the glucose rise. So this kind of helps that release right after meals. So again, good for people with, that have sporadic meals. So theoglitazones, this is the glitazones. They reduce glucose levels by decreasing insulin resistance. So only for type 2. Mainly they're added on to metformin, and that's kind of why I put them here. These glitazones, again, the last name of glitazone, troglitazone, rosaglitazone, and pioglitazone. And I just listed these on here because I've actually seen them ask this in test, or in some Hesse. Hopefully it was a few years ago. They won't have them anymore. These are off the market because trioglitazone caused liver failure and rosaglitazone caused cardiac events. Pioglitazone is still around, but it has a possible risk for cancer, for bladder cancer. So why would you use it if you have 10 other classes of meds? So again, the only one left in this class is pioglitazone. Actos is the brand name. Usually you see it in combo. So again, that's why I put it in pioglitazone with metformin. Okay, the gliptins, DPP-4 inhibitors. These are expensive drugs, but these are pretty good drugs, and I would make sure you know these drugs. So sitagliptin, saxagliptin, linagliptin. You may be familiar with Januvia is the brand name. These are expensive, weight neutral, so they're not gaining weight. That's a good thing. So DPP-4 inhibitor is also called the gliptins. Okay, so what's their mechanism of action? They inhibit dipeptylate dipeptase 4 in the small intestine. So nobody wants to say that long term. So they inhibit DPP4 in the small intestine. So this is where that word incretins is coming in. So what happens in the small intestine is after you eat, remember the glucose breaks down. You know what, let me skip to this and I'll come back. So we did not discover incretins until the mid-90s. So the hormone was found while they were researching a weight loss drug. I won't get into the monster. But anyway, so they found incretins when they were looking for a weight loss drug. So what happens is incretins are produced in the small intestine right after you eat. So the incretins actually go to the beta cells of the pancreas and they boost the amount of insulin. And they're responsible for about 60% of the insulin that comes out of the pancreas post-meal after the insulin secretion. So if you recall on the very first slide, I told you that type 2 diabetics have problems with incretins. So let's review that again. So your small intestine, they're after incretins, they're produced in the small intestine. So remember when you eat, you chew up that food, it goes down in the small intestine, glucose molecules start to get released. So after you eat this big lunch, a piece of birthday cake, you go down, the glucose starts to, you break down the glucose. It signals this hormone incretins, and the incretins go over to the beta cells, and they say, come on, we need insulin. We need you to come out. We need a lot of insulin. It's responsible for about 60% of that post-meal insulin secretion. But remember, in diabetics, the incretins are impaired. So normally in us, the incretins go in, they release, they allow the insulin to come out from the pancreas. But there's an enzyme called DTP4 that inactivates the incretin hormone. Because in you and I, if we're not diabetics and we ate this big sugary meal, sure, the incretins are going to go to the pancreas and say, come on, release some insulin. But after a while, the incretins better shut off, because if they don't, we're going to be on the floor with a blood sugar of 0, right? So DPP4 is the enzyme that inactivates that incretin hormone. Okay, so are you still with me? So again, these drugs are DPP4 inhibitors. So they inhibit that enzyme that's responsible for breaking down the incretins. So again, incretins are responsible for 60% of the post-meal insulin secretion. But again, the action of incretins is impaired with diabetics. So these are called the gliptins. So once again, you eat the sugary meal. Right after you eat that big dinner with your birthday cake, the glucose molecules start to break up. There's a hormone called incretins. It goes over to the pancreas and says, come on, I need you to release insulin. We got a lot of glucose we need to send to the tissues. So the incretins signal the pancreas to release. And then after a while, in you and I, the incretins need to become deactivated or break down, because our glucose levels or our insulin levels would be, too much insulin would be released and our glucose levels would go too low. So this enzyme, DPP4, is actually what tells the incretins stop. So we're giving something to inhibit that enzyme to allow any of those functioning incretins to keep working. If you need me to explain that in class, I can do that again. So again, spinagliptin, saxagliptin, linagliptin. They reduce the A1C by about 0.5%, weight neutral. Most common adverse effect, upper respiratory, UTIs, headaches, possible pancreatitis. That's questionable. Again, I just put these on here for combinations, just in case you see them on clinical and think, I never learned this drug. So Acto plus Met is metformin and pioglitazone. You have the sulfonylureas, glipizide and metformin, glipiride and metformin, pioglitazone and glimepiride, and Janumet is saxagliptin and metformin. Okay, so let's talk about acute complications of poor glycemic control. Diabetic ketoacidosis. So this happens in type 1 diabetics. Hyperosmolar hyperglycemic state happens in type 2 diabetics. So the cardinal features are both, they have a hyperglycemic crisis, associated loss of fluid, and electrolytes. Both conditions can be life-threatening. Treatment is similar for both. So hyperglycemia, so type 1 diabetics, something happened with their pump, or they had an illness or an infection which caused higher cortisol levels and higher blood sugar levels. It could be menses. Sometimes there's decreased insulin sensitivity with the estrogen and progesterone fluctuations. Stress just causes the the blood sugar levels to elevate. Certain medications can cause this. So whatever the reason, it's severe hyperglycemia. There's no insulin on board whatsoever with DKA. So the kidneys can't absorb the glucose. It starts spilling into the urine. So remember, this is your 3 classic Ps. So polyuria. The kidneys can't absorb all that glucose because it's way up high. Some of these patients with DKA, their sugars can be 600. Starts spilling into the urine, and as it's spilling in, the glucose is taking fluid with it. So it causes this osmotic diuresis, and the patient dehydrates. Lipolysis and accumulation of free fatty acids. So remember, there's no insulin on board, so the cells aren't getting their nourishment. So the cells are starving. So they're eating fatty acids and anything else they can find, and they're releasing these ketones into the system. So you start to get ketones in the urine. You get this fruity smelling breath. So again, 1 in 4 cases of type 1 diabetes presents with DKA. Blood sugars are greater than 300. Like I said, I've seen them even way higher. And it creates an acidosis in your body because there's nothing to feed the cells. So the cells are just eating anything they can, and they're releasing all this ketones. So this ketoacidosis. So these patients have a pH level less than 7.3. So remember when we talked about ABGs, if your pH does not stay in the normal range between 7.35 and 7.45, you're going to die. So these patients that go into a diabetic ketoacidosis, their pH starts to go way down. And again, if you're at 6.8 death, it's too high. So again, severe less than 7.1. So again, DKA, usually it's abdominal pain and vomiting. The dehydration causes them to be, they start to get dehydrated, excessive urine output. They go into respiratory distress. And usually what you'll see is Kussmaul's respiration. So remember, they're in an acidotic state. So Kussmaul's is when the patient's trying to breathe off acid, because remember, your ABGs way back here, this is 1 part acid is carbonic acid, and over here is your bicarb. So remember, if you retain too much CO2 in your body, it combines with water and it becomes H2CO3, carbonic acid. So what happens is the patient's trying to compensate by doing what's called a Kussmaul's respiration. And I have a video on that. So I'm going to, I'm going to show you this video. I know you can watch this on your own, but I know this is confusing, so I'd rather you just see this. Again, this is Kussmaul's respiration. Okay. Um, Hopefully I didn't screw that up. I'll show you that in class, so make sure you watch that because that will kind of pull that all together. So again, DKA usually abdominal pain. I went through this already, and if they again, no insulin's on board at all. So dehydration is your biggest concern. You want to give IV fluids. Check your electrolytes and your pH. If potassium's less than 5.5 and the patient's urinating, you want to give regular insulin. Check electrolytes and pH every hour. I'm giving you a little introduction on this. You're really going to get DKA in senior years, so don't get too crazy right now. Again, that's Kussmaul's that you can watch again. The other disorder is hyperosmolar hyperglycemia state, also called HHS or HHMS. So this is similar. We have a high glucose level, but it's non-ketotic. So large amount of glucose in the urine, dehydration. So they have a lot of glucose being spilled into the urine. It's creating an osmotic diuretic. Increases the blood concentration of electrolytes, particularly glucose. So the blood starts to get thicker and becomes sluggish because we've taken all the plasma away, all the fluid. The ketone level isn't really an issue here because this is usually with type 2. So there is a little bit of insulin on board. So it's not really affecting the pH. So we don't worry about an acidotic state with them. It's not really sweet or acidotic smell. Occurs most frequently with type 2, usually an acute infection or some other stress. And it usually evolves slowly. We see this with the elderly. So changes could begin in a month or two before signs become apparent. If it's left untreated, it can lead to a coma or seizures. So you want to correct the hyperglycemia and the dehydration. So you're usually giving IV insulin fluids and see what any of their electrolytes that are off. So again, I know I kind of went through these and probably confused you, but DKA you see with type 1. HH, hyperosmolar, hyperglycemia, hyperosmolar non-ketonic you see with type 2. Again, with the elderly, it's usually more gradual, but both are a hyperglycemic state. And dehydration is usually the biggest issue. So these are some questions we can go through. A patient is prescribed insulin glargine, which statement would include in the discharge instructions? So the answers are at the bottom, so you could go through these. And that's it. When you realize that you forgot to give your insulin for a big meal you ate hours ago. Okay, so I'm going to see you on February 12th. I'll be in my office. If you have any questions before that, just email me. And when we meet again on Monday the 12th, I'm going to start a new lecture, but I'm going to ask you questions on this lecture. So be sure that you watch this before and